Well, thanks for joining us here at CEDA today for another one of the conversations that we're bringing to you digitally as we all attempt to deal with the changing environment around us, but continue to engage people in really important conversations about policy and Australia's social and economic development. Today I have with me Stephen King, who's a Commissioner from the Productivity Commission, who's leading the inquiry on mental health. Stephen, thanks for being with us.
Thanks, Melinda.
Really great opportunity, I think, to find out where you're at with the inquiry, but also talk a little bit about some of the mental health issues that are probably emerging right before us in the face of this COVID-19 crisis. So perhaps we can just start off, getting you to tell the audience a little bit about what the inquiry is, how it came about, and sort of where you're at.
Yep. So the inquiry is looking at the mental health system in the broad. There's been many inquiries into the mental health clinical system. What our inquiry does, which is somewhat unique, is looking at the mental health system, including community services, including mental health in education, mental health in workplaces, in all settings. So it's an economy-wide look at how we can improve Australia's mental health and the mental health of Australians. To put it in a bit of context, our draft report came out with some numbers which are shockingly high. If we look at the cost to Australia of poor mental health, then we're looking at around 10% of GDP per year. Now, that's made up of some direct numbers, about 18 billion a year, which we spend directly on mental health services. Then there's another about 32 billion, which is a direct economic cost due to absenteeism from work, disability to participate in the workplace. That's both for the people who have mental health issues and for their carers. Then we have around another 130 billion, which is the cost of reduced health and welfare for individuals. This is a real economic cost. In some ways, it's reflected in a real loss of life to people with mental illness. People with severe mental ill health have around a 10 to 20% year reduction in their life expectancy. And that's got a big cost to Australia. It's got a big economic cost, direct economic cost, because they can't participate as well in the workforce and in society in general. And it's obviously got a huge human cost.
Yeah. Let's just follow up a bit on that. I think it's really interesting to see the focus that we're now seeing on the economic cost of mental health and a lot of focus on calling out some of the issues that play out in the workplace in a way that we probably haven't done in decades gone by. But the Productivity Commission, I think most people think of as this sort of, economic organisation that thinks very much in terms of the impact of the economy and GDP, maybe workforce participation. But having worked there myself, I know that sitting beneath that is a really important societal lens and trying to quantify and think about what the impact on society is and really from a human perspective. Through your inquiry, how are you sort of dealing with that and trying to capture that as well?
Yeah, a lot of that means listening to consumers and understanding what consumers and carers need and whether their needs are being met by the current health system. And unfortunately the answer often is no, those needs are not being met. So one of our key recommendations from our draft report, and will be carried through to the final, is that we need a much more consumer-centred system. We need a system that focuses on helping people not just to recover from mental ill health, but to maintain their mental health, to prevent mental ill health from arising, to improve participation in community, and to improve participation in the workforce. That's a good thing for the individuals. It's a good thing for Australia in straight economic terms. And it's actually a good thing for the government because a more consumer-centred mental health system will actually avoid people turning up again and again and again at intensive care, at emergency departments, at the most expensive parts of our health system.
Yeah, no, I think that's a really good point. There's lots of things that we could sort of unpack here around the mental health system. And we don't really have all day. So let's focus in on one of them that I think you were just alluding to. which is this issue around prevention. Here at CEDA, we've done a lot of work already on entrenched disadvantage, and we're committed to doing more of that. And I think that what we found sort of picks up on some of the themes that you were just raising there. You know, you see people who are deeply disadvantaged. They often are confronting issues across a range of different areas. So problems accessing housing, unemployed, they may have issues with addiction, and then often mental health problems. One of the things that we're really focusing on is how we get ahead of that.
Yep.
And I think getting ahead of mental health issues is really critical. So I'm very interested in what the inquiry is focusing on there, and whether you can give us any insights around where we might need to go with that.
Yeah, so there's really two factors there. For prevention, to help avoid people becoming mentally ill. And when we're talking about people becoming mentally ill, mental illness first presents in general in young people. So those people who during their lifetime will have mental ill health, 75% will have their first symptoms under the age of 25. That's why the costs are so high, because if you're a 15-year-old and you're starting to develop mental ill health and you're not receiving appropriate treatment, that can mean dropping out of school, perhaps dropping out of home, perhaps living on the streets. That affects your entire life. That is a life that has been lost, in a sense, to the Australian. The other side is in terms of the services that are available in community. A simple example, you mentioned housing. One of the problems that we've discovered is that people are not infrequently released from hospital, where they've been treated for their mental illness, into a situation where they have inadequate, inappropriate, or sometimes no homes to go to. So it's not surprising when those people are now faced with huge stresses and end up back in emergency 2 or 3 weeks later. And that's a terrible outcome for the individual. It's a terrible outcome for our health system. To get around these sorts of problems, we need to improve community services. We need to make sure we have a community service system that links in with the more traditional clinical health system, and we need to get that focus on prevention. We need to make sure that we're going right back to the early days of an individual life, thinking about the family and the family circumstances. Now, some of those circumstances, the stresses, poverty, housing and so on, they will be beyond our inquiry. We're not going to solve poverty, for example, in this inquiry. But understanding those stresses and making sure that the help is there for the families as early on as possible is one of the ways to help prevent big cost of a health system later on.
It's one of the issues that we pick up on in our entrenched disadvantage work as well, actually, trying to figure out how we can get a really early head start on understanding who may find themselves on the path to disadvantage, and how you can get those early preventative measures in there, which of course requires working with families to understand the totality of the family circumstances and addressing all of that rather than looking at one silo, which issues I'm sure you're very familiar with. Stephen, one of the things that I think is really emerging right before us, and it has been for a number of months now, has just been the impact of a number of really significant crises on the community, and a lot of conversations around the stress that that's putting on individuals, the anxiety that that's creating, and how that may be manifesting through mental health circumstances. And so I'm thinking, of course, of the bushfires early on in the year, and now here we are with the COVID-19 crisis. How do you think about that in terms of how the system's responding from a mental health perspective? Is the system set up to be able to deal with those emergent issues, and what could it do better to sort of respond to these things that are completely unpredictable? Yeah.
So the system does the best that it can. The relevant clinicians, the relevant community services try and fill gaps that are created by stress, by emergencies such as bushfires, such as the current COVID-19 crisis. But we really need a much more flexible mental health system. The best part is that the sort of services that are available using technology are in general already there. They can be rapidly increased in scale. The evidence is there but they are very effective, and in many cases as effective as face-to-face interventions. And of course they can be accessed in areas where there are not professionals. So at the moment, if there is a bushfire in regional rural Australia, unless you actually get the clinicians to move temporarily to that area, there simply isn't the workforce. But if we can use technology to get the workforce there, at least virtually, and start dealing with the stress and dealing early with the mental health issues that are coming out of that stress, then we can nip problems in the bud. We can actually we can have a healthier Australia out of that.
I mean, I think that makes complete sense. And let me join a few other dots and ask you another question. You know that when I was at the Productivity Commission, I worked on the data access and use inquiry. In that space, we really mounted a very strong argument, I think, that data and using data better was fundamental to improving health outcomes and improving the effectiveness of our healthcare system more broadly. You yourself have been involved in some really serious looks at how we deliver human services more broadly better. It's something that the Productivity Commission has called out repeatedly as a really ripe for change. One, to get more bang for your buck, and two, to more importantly get better outcomes for individuals. If you look at what you're sort of unpacking in the mental health inquiry, and if you're looking at where the challenges for the health system are today, both mental health but now with the pandemic more broadly, what's your sense of whether you think there's going to be a real appetite for serious reform using data, using digital delivery methods, or with a view to getting better outcomes?
With the mental health space, if we don't use technology, we don't get better data, we will not make progress. It's as simple as that. To increase access to services, we need to use technology, and the evidence is there that it works, that the therapy works for individuals. On the data side, the trouble is that once we start moving down the mental health spectrum into the higher level, if I can call it that, clinical interventions, we actually have very little data about what works in practice. So at the moment, there is a lot of money going into the clinical part of the mental health system, into programs that collect no data on consumer outcomes, so we don't know if individuals are getting better, and these programs have never been evaluated. So to fix that gap, our draft recommendation was that the National Mental Health Commission be transformed into a body that can oversee the evaluation of programs on a rolling basis, with the objective being that over the next 5 to 10 years, we move to a culture where the government funds things that are shown to work. And if you haven't got the evidence that the intervention works, then you either run the trials or you don't get the funding.
Yeah, really important point, and just absolute hobby horse for me.
You're not alone.
The lack of evaluation in programs where we're spending so much money, and you see it here in Australia, you see it in other countries as well, and I think actually particularly when it comes to mental health, there seems to be this sort of view that it sort of stands aside from the sort of normal approach that you would take to understanding whether something's working or not. And I'm going to just ask you about something else too. Did you want to say something about evaluation?
Just one for your members on this. Many of your members will know that in the workplaces, the biggest problem for employers is not the lack of potential services, programs that they can offer in the workplace. It's that there's so many of them and they don't know which ones work because none of them have been evaluated. So employee assistance programs, for example, there are no standards, there is no evaluation. The employers that want to do the right thing for their employees are working in an information vacuum. And if we can improve that, then many employers want to do the right thing and they will do the right thing because it's good for their business as well as for their employees.
So I was going to ask you something else, but now you've opened that door. So let's walk through that door. We've obviously got a lot of members who employ a lot of people, both in government, community sector and in business. What do you think they can be doing to help and support the mental health of their employees. You've talked about EAP programs and all the rest of it, but is there a message that you're looking to get out through the inquiry around what the expectation should be or might be on employers?
Yeah, there is. You mentioned the programs. We're looking at some potential reforms to workers' compensation so that we can get treatment to employees that have developing mental health issues earlier without it being a conflict situation due to the insurance process. But the biggest message that we can get out for employers and for workplaces and for society in general relates to stigma.
Yeah.
So there is terrible stigma around mental health. Just to give you an idea of the effects of stigma, the estimate is that there's around 1 million Australians each year who would benefit from mental health treatment, who do not seek it, with the main reason why they do not seek it is because of the stigma of seeking mental health treatment. And these are not just people with mild anxiety or mild depression. They go right across the spectrum, including people who have severe and chronic mental health issues, but the stigma is such that they suffer in silence rather than getting the treatment that they should be receiving.
And do you think, is that stigma still a sort of a societal stigma, or do you think they're more directly worried about their job prospects or what their employer might think if it's found out? I mean, do you got any sense of that, or is it just?
I think it's both. I think it's both. There are systems in place, for example, in the insurance system, and we called out some of those in our draft report, where stigma and discrimination is institutionalised in various parts of our system, in the insurance system, in the employment system, and so on. But it is a broader issue. If somebody has cancer now, we don't sort of, oh, gee, we don't want to talk about that. You'll talk about the treatment, you'll talk about how is it going, and we have an understanding of the treatment and the recovery from cancer. It's a chronic illness, but we understand that as a society. For mental health, we have yet to reach that level of understanding. So somebody with psychosis, our immediate reaction if we see somebody who's having a psychotic incident is to say, oh my God, I'm in danger and I better call the police. The fact is that that person is far more at risk of harm from others than they are at risk of harming others. And unfortunately, our first responders don't currently have the supports that they need to be able to respond in that situation. Because if you're a police officer caught out there, you don't know if this person is psychotic or if they're on ice. And your response is going to be very different depending on what the problem is with that person.
So where do we go with that? I mean, is this? I know personally, I've got friends who've suffered mental health issues, and it is interesting. The reluctance to talk about it. I actually try to encourage people to talk about it all the time. I think there's a whole bunch of things that happen to all of us that, when it happens to you, you sort of lift the lid and it's like, oh, I didn't realise that was you and that was you and that was you as well. And as soon as you do, and you've got a circle of friends who can lean in from your perspective, it makes it so much easier.
Yes.
And it seems, I've seen this happen in my circle of friends and family, and more often than not, when you sort of it comes up, people go, yeah, well, I know what you mean. But it seems to get hard. It seems hard to break beyond that. I mean, is this an education campaign issue? Is it, let's have the conversations in the workplace? Could be fraught. Is this something that your team's turned its mind to? Is it beyond the remit of what you're talking about, or?
It's not beyond the remit of what we're talking about, and it's not easy to solve, but it has to be a whole of community response. So it has to be in workplaces, in education systems, so that kids at school learn about mental health as they learn about physical health. It has to be the discussions so that it's not something you don't talk about. One of the amazing things from my perspective is being involved in this inquiry, and the number of people that I talk to, many of whom I have known for years, decades. And when I say, I'm on the Productivity Commission's Mental Health Inquiry, what are you doing? I run through what we're doing. They say, my brother's got schizophrenia.
Yeah.
My father had chronic depression, never understood why he would sit in the dark for hours. As a society, we have to have more of those conversations. The parallel we've been running is actually with the road toll. We got down the road toll over a 30-year period, and the way we did that was by pulling a whole bunch of levers. Partly it was through education campaigns, partly it was through regulations such as seatbelt regulation, partly it was through improvements in automobiles, making the infrastructure safer. We've got the road toll down, so the road toll now is about, I think it's about 3 people a day off the top of my head. The suicide rate over the same period of time has been increasing, and it's now running at about 3 times the road toll. So we need that whole of community response to get the suicide rate down. We need a whole of community response to be able to deal with this issue of stigma. And when we do that, that's when we'll really make headway and we'll be able to progress.
One of the issues just in the workplace that I pick up on, to be honest, as a board director, is how we've got our teams placed around managing people's performance and performance management conversations. Because in my experience, I've actually had situations where, when you trace back performance that's changed in an employee suddenly, and you have to start having that conversation, what's revealed is that there is actually an underlying mental health issue or episode. Now it's really difficult because you've got to manage that very carefully, but it has been interesting in my experience just how often when you've got an employee who's previously been fantastic and their performance becomes really erratic, or their performance just really starts slipping, that if you take the time to have that conversation and you're prepared to have that conversation directly, that you actually start uncovering some really significant issues that, of course, you can then put in place programs and support to help address. So, I think there are ways that employers really need to be thinking about this differently. It requires a degree of courage, and it does require a whole of systems approach, because you've now got to be training your managers to be thinking about how they're dealing with this in the right way. So I think there's a lot in that. Really looking forward to seeing where this inquiry goes. We've got you slated to come back and talk at CEDA in June.
Correct.
We'll see where that will happen. It's going to happen, but if we can't...
Live or online?
If we can't hold public events at that point in time, we are really committed to making sure that this important issue gets the focus that it deserves and bringing people into that conversation. I think there's huge appetite for it, and I think it's, as you pointed out, when you look at the trends around suicide, we all know the trends around mental health issues, particularly for young people. If we don't get a handle on it now, this is going to be a real problem for us at a personal level and a human level, but also from a health systems perspective and how we manage the costs and the right service delivery there. So thanks so much for being here today.
Thanks, Melinda, and thank you to CEDA for all its support.
Great, thank you so much.